everybody. Recording live from somewhere. This is Zach Cupples with episode number 134 of the Movement Debrief. And today, folks, GIRD's the word, spins the verb, lovers it curves, so freak what you heard. Oh, because we're going to talk about shoulder internal rotation. Something your boy can only dream of feeling. Yes, ladies and gentlemen, boys and girls, children of all ages, if you have issues with shoulder IR, you got GIRD, you got a depressed chest, I got you taken care of, because your boy, Big Z, has got a bunch of questions that have been asked by the people. They will be answered for the people by this people right here. Fam recognize fam. Without further ado, let's debrief, shall we? The first question comes from 612 IVO. Interesting names that we get nowadays. But here's what 612 IVO asks. How do I improve my shoulder internal rotation? And by that, I mean dealing with shoulders that have rolled forward and are not budging, no matter what drill I try. Perfect. So first, let's figure out what we're talking about. From a visual perspective, what 612 IVO is talking about is someone who has a depressed chest, shoulders drooping forward, and likely a forward head posture. If I break that down for you, Degeneration X style, what that will entail and the way an internal rotation loss happens is as follows. If the chest is drooped forward, that means that the anterior thorax is concentrically biased. Stuff is short on the front. What that does is, if my hand is the sternum, as it depresses the sternum, it kind of pulls it down and back. When the sternum goes down and back, a common issue that is dealt with by Zach, the shoulder blades, the scapula, are going to round forward. That's going to be scapular abduction and internal rotation if my hands are the scaps. Meaning that likely, although obviously this is going to be dependent on other compensations, the chest wall is going to be concentric and the posterior thorax will be relatively eccentric when you see this phenomenon. Now, if I round my shoulders forward, the humeri are internally oriented. Now, if my hands are in this position, I can't really do a whole lot, right? I can only give like upside down handshakes. And ain't nobody got time for upside down handshakes. So what we have to do in order for us to perform actions in our day-to-day lives is to right ourselves back to center. One common way that we do that is by externally rotating the humerus. No joke. If I externally rotate the humerus, that means the humerus is concentrically biased into external rotation, meaning I have concentric tension in muscles like the infraspinatus and no muscle finer than good old teres minor. If those muscles are concentrically biased into external rotation, you go to IR, you're going to have a limitation. Because if I'm concentric into ER, that pushes synovial fluid into the IR direction, and you can't create the shift in fluid. Therefore, you have a loss of internal rotation. There are other things that could potentially happen. Obviously, someone can have concentric actions in the posterior thorax, but if we just break down to how is shoulder IR lost, and we're not looking at anything else, it's concentric chest wall, shoulder blades round forward, humerus externally rotates to compensate so you can move your arms in a useful manner. So then, what you have to do to fix that, or to improve upon that, is to flip-flop that relationship. Really, the name of the game is to drive air into the front of the chest. Now, I want to caution you, 612 IVO, and all you other users. If you're thinking that, you're like your boy Big Z, and you got the rounded forward shoulders, you got the forward head posture, that all of a sudden you're going to do this, and you're going to have this nice, beautiful, sexy, upright posture, your chin's going to be in line, and everything's magical. False. It's not what happens. The degree that we can influence our static posture is going to be idiosyncratic. It's individualized. Because some of this, most of this, has likely structural and anthropometric influences. And you can only manipulate your structure to some degree. I'm built to be a runner. My chances of being a high-level bodybuilder are on the low, unfortunately. I've succumbed to that fact. Even though, I'm still going to be working on biceps, but like in terms of what I will excel at, it's probably not that sport. We can look at posture, static posture, in the same vein. Someone who has a forward head, rounded shoulders will only be able to change the static presentation so much. And I will caution you, I don't think the static presentation matters as much as you think, because we are not static creatures, even though this day and age makes us not move as much as we should. What is important is that we have all of our movement options available, because what that does is that will distribute forces more adequately across the body and allow you to perform better at higher levels, because you have more options available to you, and then tissues won't get overloaded. If I stay stagnant in any one position for a long period of time, I'm going to develop tissue ischemia in that area, meaning there's going to be a reduction of localized blood flow. That makes stuff cranky. If you are concerned about static posture, be more concerned about making sure that you're moving and grooving. That being said, we can still tackle pump handle. We can still drive air into the front of the chest to improve and influence our movement options. This may lead to some changes in posture, and it can definitely lead to some changes in your WAC internal rotation measures. How do you do that? Well, I'm glad you asked, because what you do about it depends on your structure. Are you a narrow infrasternal angle, or are you a wide infrasternal angle? I have a detailed post that talks about how this will, or what the infrasternal angle is. It will be linked in the show notes, which will be found on zachcupples.com/shoulder-internal-rotation. So check it out after. If you're watching this live, go ahead and check that out, because I actually write like full blogs to summarize this. And I think you'll learn better if you watch it, you listen to it on the podcast, and then you read it. That way you got 3 different ways to get your learning gains on point. So check out the show notes. Driving air in the front depends on infrasternal angle presentation, because the reason why a person is restricted is different for each ISA presentation. The first one I'm going to talk about is a narrow infrasternal angle. So if you're a narrow ISA, chances are you have an ISA that we'll say is 100 degrees or less. A narrow infrasternal angle has a concentric anterior thorax as part of the structural bias that that person has. With a narrow ISA, they're going to have a relatively counternutated sacrum, meaning the sacrum is going to be tipped back, so that person, from a chances of where they're going to fall perspective, is more likely to fall backward, because when the sacrum counternutates, pelvis tips back, you don't want to fall. So the first line of defense against that structural bias is to concentrically bias stuff on the front side of your body. Hence, the pump handle restriction, or the concentric anterior thorax. In order to improve this restriction for a narrow ISA, you need to make the structure dynamic. Meaning, if I'm a narrow ISA, that means my side-to-side dimensions of my rib cage are reduced, so they're smaller, hence the narrowing of the rib cage. So you got to do things to blow out the sides. In order to blow out the sides, you need to decrease the anterior and posterior dimensions. A great way to do that is by reaching straight forward, 90 degrees of shoulder flexion. When I reach at about 90 degrees of shoulder flexion, what that's going to do is it's going to drive the scapula, the shoulder blade, into external rotation, meaning the posterior thorax is going to be more concentrically biased. So that's going to push air into the front. Now, you're also going to get some degree of concentric bias on the front side of the chest because of pec activity, But in terms of where the tug of war wins, it's still going to win with more restrictions posteriorly, more air anteriorly. This is especially true if you choose an activity like a lazy bear, which if you don't know what that is, that would be basically on hands and knees, a quadruped position. With that particular exercise, now you have gravity pushing things down, meaning when you take a breath of air in, more air is going to go into the front of the chest. Life is good. Because of that position, reaching forward, you get relative A to P compression of the rib cage, which will allow for lateral expansion of the rib cage, increasing the structural dynamics. And if you choose something like quadruped, you can use gravity to push more air in the front. You do that, and guess what, folks? You're going to have increase in anterior thorax expansion, and that can influence the scapular positioning that we've been talking about. That is a little bit different when it comes to a wide infrasternal angle. Wide ISA, someone with an ISA greater than 100 degrees, we'll say. For this person, the restriction in anterior thorax expansion is a secondary compensation. I'll link stuff talking about primary and secondary compensations in the show notes. Meaning, the structural influence is a bit different. If I'm a secondary compensation, for a wide, their first instinct, because the sacrum is relatively nutated, is to fall forward. So their first line of defense is to concentrically bias the backside of the body. If that pulls me too far back, then I'm going to need to do something to concentrically bias the front side of the body. That's where you get your pump handle restriction, or your concentric bias of the anterior thorax. For this person, you still have to respect the underlying structure. If I choose the quadruped exercise I talked about and I reach straight forward, that's going to concentrically bias the backside and the front side to some degree. Meaning, guess what? You're going to get lateral expansion of the rib cage. The wide infrasternal angle doesn't need that because they're already expanded laterally. You got to do things to squish the sides so you get greater A to P expansion. Think John Belushi in Animal House. I'm a zit. Got it? Guess what pushes the mashed potatoes out of your mouth in this case? It would be in the upper thorax, the serratus anterior. Now, if I were wanting to increase concentric activity in the serratus anterior, what would I do? Well, by golly bows, I'm going to need scapular upward rotation and protraction. A great direction to create that reach would be about 110, 120 degrees of shoulder flexion. That's going to bias more scapular upward rotation. It's going to give the serratus anterior leverage to squish the sides of the rib cage, allowing you to get A to P expansion. So you still putting some respect on the name of that person's structure. Narrow ISA, I want to reach forward to get pump handle. Wide ISA, I want to reach 110, 120 to get pump handle. Of course, folks, that you are stacking, right? If you aren't stacking, you're not talking to Zach in. So make sure you have that first. So stack, reach based on what the ribcage structure tells you. That's step one. Step two, another way that you can get expansion in the front of the chest would be with anything that involves scapular retraction and shoulder extension. Because if I'm pulling my shoulder blades back like a row, that means I'm going to have more concentric bias in the back side of the body. More air is going to get pushed in the front. I usually start with the forward reaches that I talked about first. Then if someone's still limited in IR and they look good from a stacking perspective and a reaching perspective, then I'll go with something like that. To summarize, so far, what you got to do is reach depending on what ISA presentation you're dealing with. Narrows are going to reach forward. Wides are going to reach at 110, 120. Finish the job with some scapular retraction stuff, and you should have some air in the front of your chest, and life should be good. Asterisk moment. Unless you have some issues with the upper airway. Because another reason you could have a concentric anterior thorax may be because the forward head position is driving the pump handle down. One may attain a forward head position because of an inability to nasal breathe. And this can be for a wide variety of reasons. You could have a local nasal restriction. You could have a high palate. And a high arched palate will compromise the floor of the nose, and that can make the airway restricted. There could be restrictions in the throat, lots of different possibilities. If you want to learn more, I would definitely check out the myofunctional therapy post that I did. And also, too, when I release the podcast with Dr. Hockel, I'm hoping that comes out this upcoming week. Check that out. It's going to be Airway Orthodontics with Dr. Hockel. That will also go into great detail in terms of where potential restrictions in the upper airway can be. But if for whatever reason you can't breathe through your nose, what can happen is your tongue posture will drop down and back, decreasing space in the throat. That will allow you to better mouth breathe. Because if you can't get air through your nose, you still got to breathe. So if the tongue sits down and back as opposed to up on the palate, well, now I can breathe through my mouth. Life is good. But the issue is when I do that and the tongue sits low, the jaw gets pulled back, which decreases the airway space. So guess what you can do as a wonderful compensatory strategy to make sure that you get air in through your mouth? You can shoot your head forward, which is OA extension and lower cervical flexion. That position increases the airway dimensions in the throat. That's one reason why when you're giving CPR to someone, you tip the head back, is because it increases the airway dimensions. So there are obviously a lot of different ways you can impact upper airway positioning, depending on what you're dealing with. And it goes beyond the scope of what I can talk about in a debrief, because it really does require a thorough evaluation of a lot of different influences. But from a movement perspective, the two #major keys that you can focus on would be teaching yourself to attain a palatal tongue posture, tongue on the roof of the mouth. And then two, the other thing would be working on swallowing, because when you are in this forward head position, the hyoid, and it's different if you have multidirectional restrictions, but the hyoid is more depressed. When you do swallowing exercises, that can elevate the hyoid and return things to some semblance of normal. To attain a palatal tongue posture, because you need that first, you need to be able to place your entire tongue on the roof of the mouth. I want you all to join with me. Say the letter N. Go ahead, do it. I can hear you on IG saying it. So when you say the letter N, think about where the tip of your tongue hits. The tip of your tongue is going to hit just right behind the front of the teeth. It's called the rugae. So that's where you want the tip of your tongue to be resting. From there, you want the rest of the tongue up into the roof of the mouth. If you want to practice that, you can go ahead and cluck yourself. If you make a clucking noise like that, the posterior tongue or the backside of your tongue will be contacting the back of the roof of the mouth. So once you can get your tongue there, you may simply just work on opening and closing, which is tough for me right now because I got my appliance in my mouth, but that. Once you can attain a palatal tongue posture, your next course of action would be to work on swallowing. So can I keep that tongue posture, put some luscious Topo Chico in my mouth, and swallow without jutting my tongue forward? If you do that, hyoid's going to be elevated, life will be good. Summarize the treatment possibilities. First and foremost, get air in the front of the chest. It's different for a narrow, different for a wide. Narrows are going to reach forward, wides are going to reach at 110, 120. You can clean up after that with some shoulder extension and scapular retraction. Also make sure you're checking tongue posture. Tongue's got to be up on the roof of the mouth. And make sure you work on your swallowing skills, because forward head posture often accompanies a concentric anterior thorax. Awesome question, 612 IVO. The next question comes from Matt. And here's what Matt asks. If someone is missing shoulder IR, how do you decide if you load an exercise either in the suitcase, low hold position, or the goblet position? Let's break this down very simply. We have to look at how reaching our arms in various degrees of flexion influences where air goes. when I do a goblet hold, and I'm going to assume a goblet hold is between like 70 to 90 degrees of shoulder flexion. From 60 to 120 degrees, you have a relative bias in anterior chest wall expansion. The reason being is because with scapulohumeral rhythm, as you're raising your arm overhead, from 60 to 120, the scapula has increased upward rotation and external rotation. Upward and then external rotation, meaning the medial border of the scapula is going to be pressed up against the rib cage. Muscles on the back side of your body, rhomboids, traps, those muscles will push the scapula up against the rib cage. Since they're located posteriorly, and if they're more concentric, it's going to be a lot tougher to get air into the back of the rib cage. But if you breathe in, you're still going to get air somewhere. That's where air goes in the front. Therefore, if I'm using a goblet hold and I have my elbows or my shoulders between 70 and 90 degrees of shoulder flexion, that's going to allow me to put more air in the front, assuming that you're not overpecking the reach. A lot of times when people do a goblet hold, if they bring the elbows in hard, they'll create a lot of tension in the pecs. If you have a lot of tension in the pecs, you're not going to get air in the front because the pecs depress the sternum, which is a concentric anterior thorax, meaning you aren't going to get air anywhere. A lot of times when that happens, people will feel neck tension. So if you're getting neck tension, you may want to check yourself and no longer peck yourself. Make sure you get the reach without engaging the pecs overly. The common issue that I see is when you're really trying to move the thorax posteriorly. And that's really like the fix for getting people to not overpeck it, because a lot of times when you're cueing the reach forward, they may just move the scaps without moving the thorax backwards. That's usually the issue. And if you move the scaps forward without getting that posterior thorax movement, the pecs will get overly engaged and problems ensue. You'll see this a lot when I coach a goblet squat on my YouTube channel, but one of my favorite cues is to make sure you shove your whole body backwards as opposed to thinking scapulae forward. So think, for those people, I need to move the body back, then get the stack, and if you do that, a lot of times that will reduce the pec overactivity that is often seen with a reach. Another good thing that you can do as well is also to teach reaches unilaterally. Now, you're not going to do that with the goblet hold, but maybe working on unilateral reaches without kicking in the pec. That can also be another great way to reduce pec overload or pec overactivity during these particular moves. Now, if you lower the goblet hold, you go with like a low goblet hold or a front rack position, and you're reaching less than 60 degrees, because the resting position of the scapula is in more internal rotation, that's going to allow more posterior expansion to occur because the scapula is IR'd. Those muscles are on slack. So you'll get more air posteriorly in that case with a low goblet hold. And if you want to dive a little bit deeper in terms of the degrees and why that happens, there's a great post I did on scapulohumeral rhythm. Definitely check it out. It'll be in the show notes. Goblet, 70 to 90, you're probably going to get air in the front. If it's a low goblet, you're going to get air in the back. Now, what's going on with a suitcase hold? And I'm talking suitcase carry, arm at the side. Guess what, folks? It doesn't have a whole lot to do with the arm that's holding the weight. The interesting thing about a suitcase carry and why it's effective has to do with the swinging arm. What happens is when you hold a weight in your hand, because that arm is fixed, it gives you a fixed point to rotate the thorax around. And this is one reason why I encourage a substantial arm swing when you're doing a suitcase carry, because you can really drive rotation around the thorax with a fixed arm. It's really cool. Think of it as like I had a spin wheel. That would be a good example. So you know the wheels that you spin and you win a prize? The middle point that the spinner is spinning on would be your arm that's holding the weight. And then the rotational action happens to be the thorax, which is driven by the arm swing. So let's say my right arm is holding the weight and I'm swinging my left arm. If I reach my arm forward, my thorax is going to be rotating to the right because that rightward arm swing is going to orient the sternum to the left. When I rotate my thorax to the right, that's going to net me anterior expansion on the left side and posterior expansion on the right side. And the reason being is because when the spinous process moves to the left, so I'm rotating to the right, spinous process in the spine moves to the left, the stuff on the back is concentric on the left and eccentric on the right because your muscles that allow for posterior thorax expansion attach to the spine's process. So when you rotate your arm, you reach your arm forward, trunk rotates to the right, you get anterior expansion on the left, posterior expansion on the right. When I swing the arm back, now the thorax is rotating towards the left. When the thorax rotates towards the left, you get the reverse action. Now, because the spinous process is moving to the right, I'm going to get anterior expansion on the right side and posterior expansion on the left side. Now, depending on what you do with the arm that has the weight, that can also influence some expansion to some degree. If I'm shoving the arm in a little bit of flexion and the scapula is more protracted, that's going to allow for some posterior expansion. If you pull the shoulder blade back on the weighted side, that's going to allow for relative anterior expansion. But that's still a fixed point to which you are driving rotation in the thorax about. To summarize the differences between these positions, a goblet hold, if you're between 70 and 90, is going to get air in the front. A low goblet is going to get air in the back. And a suitcase hold, in assuming you're encouraging arm swing, which you should, is going to drive anterior and posterior expansion because the weight position is going to allow the thorax to rotate around that weight position. So it's a great move to get air into all quadrants of the thorax. Dan asks, Big Z, during the suitcase carry, how do you cue people to maintain the stack while they're walking? Ooh, this is a good one because a lot of times when people walk, they will inevitably arch their back. And the cues are very similar to what I would do with anyone else. A lot of it would be making sure they tuck, get an exhaled ribcage position, try to hold that tension in the abs that they get from that, and just make sure you're walking in that direction. A lot of times that works. If they're still struggling, maybe you need to do some things to just be able to get them to maintain the stack in standing. With a lot of the stuff that we're doing, reaching forward, tucking, squatting, a lot of that is putting the spine into a backwards position or is going to promote backwards locomotion. So I'll give you an example. A lot of times if you're doing a retro sled drag, well, you look like you're in a squat position when you're doing that. So it makes that a little bit easier to get that stacked position. But the issue is rarely now do we propel or teach our clients to propel forward and maintain the stack. So with that, anything you can do that improves hip extension, teaching them to keep the tucked position while they're pushing their leg back, that can be very effective at getting the pelvic component. And then same thing with your rows or anything that drives the arm backward, because the backside mechanics of the suitcase carry, when you're kicking your leg back or kicking your arm back, that's when someone is going to be predisposed to losing the stack position. So drilling activities that influence keeping the stack position while the arms are going back can be effective. So working on hip extension, split squats, working on rowing, those can help teach your clients to keep that position when they're walking. Could conceive of just having them hold an iso hold position with the suitcase. So maybe you have them do a forward reach and their step, so if it was my left hand, I reach forward with my left, I have my right leg forward and I hold that position and breathe. You could do that with the front side mechanics and the back side mechanics of a suitcase carry. Have them work on the iso hold in that position and see if they can maintain position. So to summarize, Dan, because I kind of went real quick with that, I would make sure you're working on hip extension and shoulder extension, seeing if they can maintain the stack during that. Then I would go iso holds of the suitcase carry. And once you got that, then you would go through the dynamical portion of the suitcase carry, and that should help your peeps maintain the stacked position. Great question. The next question comes from the G Maya. What a good G Maya. Here's what they ask. Can you do something on pec minor strain, right side? Seems to keep recurring every time I perform any chest exercise. Keep up the good work. Let's dive into the anatomy of the pectoralis minor. Pectoralis minor attaches to ribs 3 through 5, and it also attaches to the coracoid process of the scapula, which is this thing on the front, this like little hook-shaped thing, not the acromion, but the front hook. Its actions are, at the scapula, downward rotation, protraction. At the rib cage, it's going to elevate the ribs. Now, if you're doing a bunch of chest exercises, that could potentially create some concentric bias in the front of the chest, meaning you're going to have your pec minor on stretch or eccentric proximally. Depending on what you're doing with the scapula, you could either be concentric or eccentric with the distal attachment of the pec minor. Let's say you're doing a bench press. If you got a hella ripped chest, like your boy, not really, but if you got a hella ripped chest and you're pulling the shoulder blades back, well, guess what? That's going to put your pec minor on stretch on both ends. Perhaps that's creating some ischemia locally, and it may lead to some issues, especially when you start pulling the shoulder blades back even further. So it could be that you are creating this eccentric overload on pec minor, and things are getting sore, problems ensue. So what you gonna do about it? Well, what to do about it would be to give the pec minor what it doesn't have, which is concentric action. All of the stuff that we talked about that improves the anterior chest wall expansion, the pump handle, the pump, the kind of pump that you do to get movement options, if you know what I'm sizzling. That, folks, is going to create some concentric tension in the pec minor. Because the pec minor attaches to ribs 3 through 5, it assists in elevating the rib cage, which is needed in the pump handle action, or when you get expansion into the front of the chest. Anything you can do that drives that elevation of the front of the chest may reduce the strain on the pec minor. This is incredibly important when you're talking about doing a lot of chest-based exercises. It's really hard to say to what extent, doing a bunch of activities that involve chest work is creating the bias, because I think a lot of it is structural in nature, and it could be worsened by your activities, but I don't know. It's hard to say, because what we're not doing with this discussion is, well, what if you lay off of doing training for an extended period of time? What's going to happen there? I mean, we just don't know. But from a mechanical standpoint, you need to just improve the movement options in the front of the chest, and that could potentially reduce the strain that is occurring on the pec minor. And, as counterintuitive as it seems, it would involve actually a lot of reaching, but you may want to reach without overacting the chest. You want to do reaches that will drive pump handle expansion. And if you do that, my hope is that that reduces strain on the pec minor. Awesome question, the G Maya. The last question comes from Terry. And here's what good old Terry asks. You mentioned limitations in horizontal adduction. How do you assess this? Are you just holding the rib cage down and then adducting the arm until the rib cage starts coming up? Or are you holding the scapula down? Awesome question. Horizontal adduction is a very useful measure because it's going to give you some information about manubrial expansion T2 to T4. I'll link a post in the show notes that dives a bit deeper into that. The way I assess horizontal adduction is you want to encourage humeral movement without corresponding scapular movement. That's to assess what can actually happen in the GH joint. A normal measure would be being able to get the olecranon to the nose, which is about 135 degrees. The way I'll do that is actually fixing the scapula, so I'm just getting humeral movement. Practically what that entails is not going in the armpit, but I go like just below the armpit, kind of where the meat of the lat is, and I press my thumb into anterior fossa of the scapula, but on the lateral aspect. So you're not going up way high like where the meat of the subscap is. You're going on the side. I'll put my thumb on that component of the scap. Watch your clients, in case they're ticklish, so forewarn them what you're going to do. Place your thumb on that portion of the scapula, pin it down, and then take your opposite hand and move it so you can appreciate horizontal adduction. And that's really how I test it, looking for olecranon to nose or even slightly past. If you have someone who's restricted in that position, what I like to drive is manubrial expansion, because the restrictions are like T2 to T4 level, but on the front side. Ways you can do that would be putting the arm in horizontal adduction. A great move for that is a short lever side plank, but making sure you drive some rotation with that. Another way that you could improve that would be with humeral extension, making sure you're getting some scapular retraction. Because what that's going to do is it's going to tilt the scapula somewhat anteriorly, which will allow the anterior components of the thorax to increase expansion via pec minor. So that can be another great way to improve that particular measure. Another move that I also like is, surprisingly enough, the side-lying armbar, which you would think, well, when I'm in that position of abduction, that's going to drive horizontal abduction, and why are you getting expansion on that? When I'm doing a side-lying armbar, I'm also getting concomitant cervical rotation. When I induce cervical rotation, that's going to create rotation of the thorax down to about T5. When you rotate the thorax one direction, as I talked about before with the suitcase carry, you're going to get anterior and posterior expansion. If I'm doing a left-sided armbar and I turn my head to the left, I'm going to get anterior expansion on the right side, and I'm going to get posterior expansion on the left side. Because of that, you're going to get some tremendous changes on anterior expansion in that regard. And those are great ways to improve horizontal adduction. To summarize this amazing question, Terry, horizontal adduction, put your thumb in the scap, you're going to move your arm across the body, and that will teach you how to test horizontal adduction. The olecranon should be right at the nose level. That would be what we would consider normal. If you're limited, that means you can't get manubrial expansion. So the upper segments of the thorax can't expand in the front. Ways to get that would be putting your arm into horizontal adduction, could be humeral extension, and of course, folks, driving any type of rotation, especially cervical. Jim HDSN. How about ab overactivity, particularly on the exhale? This is a good one. So the first issue that I see with people having ab overactivity on the exhale would be they're exhaling too fast. So you got to tell them they got to go about 50% slower than what they think, sometimes 70%. Cues that I like: make your exhale be 15 seconds long. It's not going to be 15 seconds long, but it should be very long so you can ensure that the abs aren't overactive. The other thing you have to watch out for is, are they getting a little bit of ab tension on the tuck? A lot of times when people use the tuck, they can't engage glutes and hamstrings to perform that action. So what they'll do is they'll tense the abs to make the movement happen. We don't want that, because now what you got is you've already concentrically biased the abs, and then they're going to have active insufficiency to complete a full exhale. And then you're going to kick in rectus, problems ensue. Make sure that they can tuck without engaging the abs and exhale slower. A lot of times that takes care of the issue. If you're still running into some problems, doing exercises that are in prone or quadruped, basically anything where your stomach is facing downward, that can be a great way to increase the eccentric bias of the ab wall. And the reason why that is because gravity is going to push the viscera into the ab wall, so it's more passively on stretch. If you do that, a lot of times you will have a significantly easier time not over-abbing the exhales. Great question, Jim HDSN. And I think, folks, that'll be a good stopping point for us today. I want to thank all of you for tuning in. If you want to learn more, the first place I would go is zachcupples.com. Subscribe to my newsletter while you're there if you want a bunch of free stuff. If you want access to my free course, Human Matrix Foundations and the Common Compensations Notebook, which will first give you the didactic foundation to understand a lot of the stuff that we're talking about in the debrief. 1. 2, the other thing that it's going to do is with the notebook, you'll be able to pick apart some of the compensations that we've been talking about here. So definitely check that out. You also get 5 hours of talks and a free acute to chronic workload calculator so you can intelligently progress load with your clientele. I also offer some services. The first is my seminar, which if you want a hands-on way of assessing the concentric expansion or lack thereof in the front of the chest and what to do about it, and just going through the debriefs isn't enough, my seminar, Human Matrix, is the way to make that happen. Unfortunately, because of COVID, I've had to postpone all of the 2020 dates, but I'm actually excited about it too because it's going to give me a lot of time to really fine-tune the seminar. I'm hoping to add a lot of different things. I've refinished. We're up to 7.0 now in terms of the tweaks that I've made to this seminar. It's going to be really solid. Dates. The first one is going to be February 20th and 21st in Atlanta, Georgia, where the players play. April 10th and 11th, Warren, Ohio. May 29th and 30th in Boston, Massachusetts. August 14th and 15th in Ann Arbor, Michigan. September 25th and 26th, Wyckoff, New Jersey, which is outside of New York City. And then I got a few that I need to reschedule in Pennsylvania, Montreal, and then Charlotte. So I'm still working on the reschedules for that. I may have a couple others signed up, but if you're in those areas, and hopefully the world is healed by then, I hope to see you at one or maybe many of them. Other things that are available to you on zachcupples.com. If you have a loss of shoulder internal rotation and you are unsure what's the best move for you, or you want to be coached through some moves because, you know what, Zach, I've tried quadruped. I've tried reaching at 120 and my shoulder internal rotation is still kind of funny. Well, maybe you need expert level coaching to get you to the next level. And that's where a movement consultation can come into play. With that, I'll perform a full assessment on you. We'll determine the best moves to get you to where you need to go. So definitely give it a shot if you haven't. If you want to improve your movement capabilities and pick the best moves to do that while pursuing fitness goals, I also offer online training. I currently have 3 spots available, and they're going like hotcakes, folks. So you probably want to check that out because if you sign up with your boy for online training, you'll get a movement consultation. You'll get 6 weeks of programming with me. I will design a program specifically to what your needs are. We will talk a couple times a week. And what I really like about the online training is I can kind of coach you on the fly because you'll send me some videos. I'll critique your form and technique to make sure you're getting the most out of your program. Definitely check that out. If you want to learn how to do this stuff with your supreme clientele, you're trying to get onto the internet side of things and you're unsure how to best do that, or maybe you're doing remote consultations and you need help with performing that, I can help you with that through my mentorship program. So definitely check that out. It's been really good, and it's more than just helping you understand the didactic side of things. I will give you feedback on how you're coaching, how you're educating, and how you're executing the plan, but you videoing, you doing stuff with your clients. It's really cool, and I've gotten some really good feedback from my peeps in terms of how that's been effective for them. Once you've scoured zachcupples.com, you'll want to check me out on Apple Podcasts and Stitcher. Search The Zach Cupples Show. Because guess what, folks? There's 133 other debriefs out there. And we didn't always have the brick wall. We didn't always have 2 camera angles. We didn't always have Well, I guess we always did have a bald head, but you get the point. So you might want to just listen to me, and it's also, if you've watched this, it's a great way to reinforce the material. Leave a review while you're there, though, so the fam can keep growing. I'm also on the social medias. Find me on Facebook and Twitter with the handle ZCouples. Of course, I'm on that Instagram, baby. Zach, Z-A-C, Cupples, C-U-P-P-L-E-S. And you can also find me on YouTube if you want to see what exercises I am applying to my supreme clientele. Test them out. Check out my YouTube channel. Search Zach Cupples. Thank you so much for tuning in. You've been a beautiful, sexy, outstanding audience. And I hope that you keep it real, but not to the extent where things go wrong. Stay hungry, stay learning, stay moving. And I'll see you next time. Deuces.